Hello, everyone, and welcome. My name is Corey Thornton. I'm the General Manager for Market Intelligence at Open Minds. Today, as part of our weekly Executive Web Forum series, Open Minds Senior Associate Sharon Hicks will discuss how to integrate social determinant supports into your existing clinical programs. Ms. Hicks has extensive experience in the health and human services field, including health plan management, clinical operations management, and technology. Before we get started, I'd like to go over a couple of housekeeping reminders. Your audio is muted today, but we would love to hear your questions. You can submit those in the question box on the right-hand side of your screen. Also, tomorrow, the slides and recording for today's briefing will be available on the Open Minds website. And with that, Sharon Hicks.
Hi, everyone. Corey, just to confirm, you can see my screen, everything's working?
Looks good, Sharon, thank you.
Okay, thanks. Hi, everyone. We are talking about integrating social determinants of health into clinical programming. This is an area that's really near and dear to my heart. And by clinical training, I am a social worker, and I have always believed in systems theory, and I've always believed in a whole person approach, and I've always believed in looking at a person in terms of their surroundings. So it's very exciting to me that we're starting to talk about this as being integrated into our normal practice and even expanded. So today we're going to focus on, three general topics: how one identifies social support needs of individual consumers, what is the 6-step process for meeting those needs, and then how do you measure the value of investment. And we will try to get through most of these presentations and then we'll go into some questions. So feel free to submit your questions as I'm speaking, and we will address them as we go. So let's talk a little bit about social determinants of health. It's been such a topic of conversation, especially once the Centers for Medicaid and Medicare Services, CMS, finally started talking about them themselves on their website in terms of introducing Z codes and introducing whole person healthcare language into the physical health arena. So we're going to start with a very basic kind of understanding, which is the social determinants of health are related to specific conditions in an environment. The environment can be where people live. The environment can be where people work. The environment can be associated with certain types of living situations. But basically, the national literature would say neighborhood built environments, health and healthcare, social and community context, education, and economic stability, and all of those together are related to social determinants of health. So it's not just, oh, I'm a person who, has extreme poverty and I'm having trouble driving to get my medicine. It's not just that. It's really broader than that. It's really this focus of what is the effect of living in the neighborhood I live in? What is the effect of, not having any access to health centers in my neighborhood? What's the effect of walking through my neighborhood and seeing discarded syringes, right? It's really everything connected. And all those things together make up the social determinants of health for a specific person or a specific geographic or otherwise defined population. So these next slides, I think, are really important because they begin to talk about how the United States is different from our partner countries. And when I say partner countries, there is something called the OECD, which I'm always forgetting what it stands for, but it's basically an organization that collects data from about 35 to 37 countries, puts those data together, make them available for people to download and do research on. And it has all kinds of information. It has manufacturing information, it has healthcare information, it has all these indicators. And I always think it's interesting to to look at the US in terms of how we look compared to others in the world. And so you can see that healthcare spending as a percentage of GDP, gross domestic product, for us is around 17%. But the nearest country is Germany at 12%. And it goes as little as Luxembourg, which is about 5%. But you can see that for the European countries, we are way outside of what one would think is normal, right? So we're definitely a few standard deviations above the mean here in terms of how much money we spend on healthcare. So when people hear this, they often say, we spend a lot of money on healthcare, but our outcomes are bad. And the reason is on this next slide, which is that healthcare spending is only one piece of the puzzle. It's only one piece of the spending. When you put human services together with health spending, look what happens to that graph. Not only does the United States move into the middle, so we're not spending the most, right? Here's France. Let me find France. Here's France, and they're at around 11%. But when you look at France here, they're spending the highest percentage of their GDP on health and social services together, right? So it's, again, that construct of a whole person. This is not just the money spent directly on medical care. This is the money spent on a person. And so when you look at it that way, all of a sudden the United States is not spending more. All of a sudden the United States is spending around the middle. But when you look at the percentage of spending within that health and social services spending, on average, OECD members spent about $1.70 on social services for every dollar that is spent on health, right? So more money on social services than on direct health. But for the US, we spend about 56 cents for every dollar. So not only a significant difference in the way that money is spent, but also a significant difference in the total spending. And I really think this slide and the slide before it captures the reason that social determinants of health are such an important thing for us to deal with as a country. There's lots of structural reasons why we do not do this, why we do not spend $1.70 on social services for every dollar, but instead spend 56 cents. The primary reason for that is because we have built up some of these as businesses, and we've built up others as social services that are supported with tax dollars. And if there's one thing we know about Americans, they don't like spending tax dollars on services for other people. This is not a country that says, oh, yeah, let's all put some money in the pot and make sure nobody's hungry. That's not the kind of ethos of the United States. And so the fact that we spend less money on social services is related to all kinds of things: the way we tax, the way that services are apportioned to federal dollars, local dollars, state dollars. All of those things are combined. And they're not. In France, it's all money at the national level. In the UK, it's all money at the national level. So it's a little bit easier to understand how we got here. But I still think that this particular slide is really powerful in terms of describing where we are. Another way to look at the same data, this is a comparative average. And so, sorry, I'm just moving my things around. So total health consumption is around 10.6%. Non-health spending is around 20%. Health and human services together is about 30%. And then here we have the US, where we're a little bit above the average, but the difference is clearly related to the proportion that we spend on health versus on social services. And then you have Australia, which spends about double the amount of their total on human services compared to the kind of traditional health services. So again, it really speaks to not just total spending, which is important because we always talk about how we spend more money than anybody else does on healthcare. And that's not true when you start looking at, Sweden or France or Austria, who's spending more than we are in total, but the proportional spend is so very different. So, simply put, social determinants of health is a whole person approach. It's a way of looking at not just the person, but all the factors that affect that person when you're thinking about treating an illness or the symptoms of an illness. And so, Flint, Michigan is a great example. You have a geographic location in which the incidence of children who have lead-related problems is very high. You can't look at each of those children individually. You have to look at what is going on with the water supply that so many children have lead-related illness. And so it's, that's population health, but social determinants of health is a way to take that population and focus it on that person. And so what does that person need because they live inside that population? So step one, as we discussed in our overview, is identifying the social support needs of an individual. So again, lots of things people can use in order to do this. There was a multi-site Robert Wood Johnson Foundation program that found that social determinants of health can account for up to 40% of an individual's health outcomes. And that was particularly true for low income populations. So the end of the study basically said, here's how you effectively incorporate social determinants of health into your programming. You assess, you collect information at a person level, you track and then try to address people's needs, and you identify available social supports for folks and track referrals and track outcomes and track the processes. So, the first item is determining how you're going to measure, what you're going to measure, and what kinds of areas your organization wants to focus on, right? So, one of the components of social determinants of health is that it does, they do vary obviously by person, and the needs can vary by neighborhood, and the needs can vary by age, and the needs could vary by economic situation. The needs can vary by whether someone's in an urban or rural environment. So you have to think about what is my organization able to do, willing to do, and what are we going to do directly versus what are we going to do through referrals out to existing organizations. So you have to think about the kind of practicality of capturing information about social determinants of health. So if I ask you if you have enough money for food, and then you tell me that you don't, and I say, oh, sorry, that is anti-therapeutic, right? I shouldn't ask the question if I don't have an answer about how I'm going to help you. I can assess it, but I can't actively be ignoring information that then comes up. So it's really important before you pick your assessment, that you take a look at what it is you're willing to do once you find the information back from that assessment. And there is an example, there's a coalition of 17 health centers in Northern California, and they each take questions from this tool that was created, protocol for responding to and assessing patients' assets, risks, and experience, or prepare, and they modify it for every service location. And so it's modified to assure that if they ask the question and the question gets a positive response, that they have a way to intervene. But there are many, many tools that can be used, and finding some that are free and finding some on the internet, very simple to do, and many of them have accompanying articles that talk about the validity and reliability of them. So there's these kind of big, broad ones, social determinant screening tool, prepare, all the things we talked about. And then there are tools that are specific components of social determinants of health, like intimate partner violence, or the ACEs screen, which is adverse childhood experiences, right? So, there's been some literature on children in certain inner city neighborhoods having ACEs scores that are as high or higher than children who live in countries where there's actively a war going on. So when you think about just that one component, right? A child from a neighborhood in the United States who's screening at the same level as a child who's living in Syria during the war, that's pretty important information to have if you're the clinical program or education program or school program that is trying to help that child, right? So knowing that ACEs score becomes really important. And once you've done that, then you're implementing social determinants of health methodology. So, I'm always a advocate of the least. Pick the technology, pick the assessment, use the least of. What's the smallest number of questions I can ask to get what I need to know? Not the biggest one, because you really don't want the people who you're asking to fill these things out to be so overwhelmed by how large they are that they stop halfway. So I always feel like asking a smaller number of questions gets you more reliable information. It gets you a better response rate, and it gets you better compliance when you want to reevaluate. So I say pick an assessment that's not too burdensome, and pick an assessment that's the most important for your clinical program. And my example is the World Health Organization Quality of Life, or the WHO-QoL, is a really nice tool when you're working with adults who have serious mental illness and you want to see how effective your programs are towards recovery. So the quality of life scale is basically a measure of how many things are you doing in your day-to-day life that we know leads to a higher quality of life, having friends, having hobbies, doing things with other people, all of those kinds of things. So you want to pick an assessment that you feel really resonates with your clinical programming, with your mission. And then you have to be also aware that there are many tools that focus specifically on an illness and its illness symptoms. So again, you may want something more that's more targeted. You may want something like the World Health Organization has something also called the WHO-DAS, which is the World Health Organization Disability Assessment Scale. There's a short one and a long one. So, the quality of life is going to be looking at how many things the person does that correlate with higher quality of life, where the Disability Assessment Scale is looking at how much somebody's illness is affecting their day-to-day activities of daily living, et cetera, et cetera. So you want to pick something that resonates. And here's an example of the Health Access Survey, which I think is a really nice kind of brief one. So this is the first 7 questions. Do you have access to a park or places for recreation? Do you need help with transportation to get to your doctor's appointments? Do you ever need help filling out medical forms, reading prescription labels, understanding how to take your pills? Are there others in your family who would be informed and consulted, who should be informed and consulted regarding your medical care? How often do you skip doses or forget to take your medicines? Does your family have access to good education and job opportunities? Do you have access to fruits and vegetables? Do you feel your physical health is affecting your spiritual life? Do you go back to your native country or visit other countries to have medical treatments? Do you have enough money to buy things you need, especially everyday things, clothing, housing, utilities, food? Do you see a native healer or a non-traditional practitioner? Are you able to get medical care when you need it? Does anyone in your family have problems with substance abuse? Do you feel discriminated, bullied, isolated? And do you take non-prescription herbal or folk medicine for your medical conditions? So this is a tool that kind of in an integrated way asks some health status questions, but also throws in some of those social determinative health questions. And again, it's only 15 questions, so it's relatively easy to do, and it doesn't take too much time. So some examples of the kinds of things people are asking and that are being determined are social determinants of health because they have a specific and direct effect on health status. Tobacco use in home, so kids who grow up with secondhand smoke or adults who live with secondhand smoke. Access to fresh food, education level, but quality of local schools, the strain, the financial resource strain, intimate partner violence or being near intimate partner violence, engaging in physical activities, having social connections, overall stress, air pollution, lead in water, access to childcare, et cetera, et cetera. So there's tons of things that are associated with social determinants of health. And that lead to a whole person effect. And so you do get to kind of pick a little bit based on what your organization is able to focus on and wants to focus on. So for the second piece of this, then how do we measure the value of investing in social determinants of health? How do we think about which part of the social determinants of health spectrum is our responsibility or what we feel has to be embedded into our mission? So there was a Kaiser Foundation study that basically found that person-centered care, high-quality clinical care was just not enough to actively address medical factors that influenced health. They found that the social and environmental factors were related, they said, to about 20% of premature deaths in the US. The finding from the study is that providers have to seek to improve the health outcomes of their patients by addressing social determinants of health, social risk factors, and social needs. One of the comments from the foundation study was that the fee-for-service models do not create any incentive to address non-medical factors because they don't reimburse providers for extending care beyond those providers' walls. So this is one of those times where the movement to value-based purchasing may in fact be a powerful lever that we can use to encourage healthcare payers to reimburse for some of the social determinative health work that we know that vulnerable patients need, or for people who live in vulnerable communities. And maybe this is a way to expand access to and to get more people to be able to think seriously about embedding whole person and social determinant of health thinking into their standard models of treatment. So there was a case study done by a mental health organization, and they basically surveyed everybody. And they used the assessment that we talked about earlier, and they found that about 10% of their population reported having some significant problems that were associated with social determinant of health, neighborhood, the community in which they lived, and resources. And it was about 10% when they did the big survey. So after they found these things, after they did this analysis and found these things out, they were able to then determine where should we focus. Again, this is a holistic approach, right? So this is like a whole population that's getting attended to. And once you find out that about 10% of your people are having difficulty with access to food, you know, having you know, no place for kids to go and play, et cetera, then you can start to think about the interventions. Interestingly enough, for that particular one, what they did was, I thought fascinating, because they focused on a few of the social determinants of health that they felt they were empowered to support. So what ended up happening was, one of the big needs they found was transportation to pharmacies. So they created a kind of naturalistic support group of patients who lived in you know, close proximity to each other, and they organized carpools. So groups of people would go in the carpool, be taken to the pharmacy, pick up all their meds, and then the carpool would take them home. It was a kind of empowering model, because it was people helping people, right? It wasn't the organization doing this. It was the organization coordinating it, but it wasn't the organization actually doing the intervention. Another thing that they did, which was really powerful, was they created an on-site food and clothing bank. So people brought in food, donated it. People brought in, you know, gently used clean clothes, donated those. They went out and they got some foundation and charitable aid, and they bought food and bought some clothes. And then they made that available to anybody who was getting service. Even though they were a mental health service agency, they said, you know, hey, if you need a box of cereal, go take a box of cereal. So it was a very kind of grassroots approach to the social determinant of health. Oftentimes it was a referral to the medical assistance transportation group so that people could get transportation to their physician's appointments and things like that. It wasn't that they were able to actively change the fact that people lived in poverty or people lived in neighborhoods where there was significant violence. None of that changed, but what they were able to do is say, where are the areas where we can make a difference? And patient satisfaction and family satisfaction rates went through, you know, really high. The next one was a large health plan that decided to outreach to their members who were caregivers to older adults. So the assessment included what services, what supports did you already have for your older adult for which you were a caregiver? And what about housing? Like, how, you know, were you worried about your person you were caregiving for having housing instability or needing assistance paying their utility bills? What about your own needs? And then what about personal and family needs? So, you know, how much of an effort were you spending on making sure that the person you were caregiving for had everything that they needed? And then transportation, which is, you know, always an issue. My own 90 some odd year old parents gave up one of their cars, and they still have a car. They need to give up both their cars, but you know, that's a big issue for people who are aging, because it makes them completely dependent upon their caregivers for taking them everywhere, right? So that was one of the components of the assessment. And then the health plan found out that about actually more than 20% of the caregivers reported needing some help. They needed some help on transportation. They needed some help on creating care plans. They needed help on getting access to resources. They needed help on, things like helping their person with veterinary care. They just needed a lot of help. And so what the health plan did was they created an in-health plan service of health coaches specifically to support caregivers. And so the health coaches were available to say to the person, I would call and I'd say, my parents live here and I need help with this. And they would then be able to give the caller referrals, and they would be able to give the caller ideas about different kinds of programs that might assist. And the result was that almost all the caregivers, 86%, 89%, reported feeling improvement in the stress that was associated with their caregiving. So, 88% felt that they could better impact the health of their loved ones. 86% felt they were more connected to their care coaches. So, it was very positive in the sense that giving people an opportunity to get assistance on these non-medical issues. This was a health plan, and non-health plan related issues really empowered them and made them feel that much more supported. And so, the big assumption is that if you help people with their social determinants of health, you're going to reduce medical care needs. So as you begin your measurement phase, you want to pick a specific target for your social determinants of health measurement, right? You don't want to, you can measure everybody, but you don't want to measure everything for everybody, because it's going to be very difficult then to develop a measurement plan. So once you assess the volume of a specific social determinant of health issue, then you can implement an intervention and remeasure the population to get a sense of the improvement. It's very difficult to determine what in fact was helpful if you measure something really broad and you implement something specific, but then you remeasure something really broad. How do you know which of the specific things you implemented were actually helpful? And so once you start small with something concrete and something measurable and something definable and something you can speak to, and you do your pre and post measure, then that begins the development of your broader measurement model. So once you get past the kind of, how do I do basically, is this program effective at getting more people access to fresh fruit? Right, that's the very concrete thing you would start at on the last slide. Then you want to start thinking about what's the value of social determinant of health assistance. What is the effect of looking at these things to utilization of services, needs for the programs to intervene. Now, let me give you a slight caveat here, which is because we live in an environment in which people get paid for the service that they do, it's very difficult to start thinking about moving away to an environment in which you're decreasing the demand for your services. This is where value-based programming becomes really important, because you don't want the financial incentive to be on keeping people high service needs. You want people to get better. And so you do need to think about the financial incentives as you're building some of these programs. It's not uncommon at all for any program that measures incidence to initially result in an increased demand, right? There's been a number of studies that say that as soon as you have somebody asking the question, do you need this, you're getting a lot more positive answers because you're asking the question. And so that's perfectly understandable and completely okay. And then when you start to think about your return on investment measurement, you want to think about all of the economic components, right? So it's really not just the direct services that you're getting paid for, but how you're working with that human being and how that human being is utilizing other services. And you can see why this is much more simple in a country like England or France or Sweden, where they have a nationalized health insurance, because then they are by definition looking at a whole person, while we in the US, depending on where it is we're working and how much value-based is already in place, we're not able necessarily to look at that next level of measurement. So as an example to this, there is a clinical program put in place by a physical health managed care company where they added medical expertise to as an intensive community-based service. And that medical expertise served to help people who were qualified for this very intensive community-based services to use their existing support system and this service delivery to help them manage some of their medical services. So medical inpatient days dropped and medical time in the emergency room dropped. But on the psych side, on the mental health side, spending went up. People were using more of that service. Overall, the spending decreased. But if you looked at those things outside of each other and you didn't put the whole person together, then one showed an increase in spending and one showed a decrease in spending. So it's important to think about the complexity of your return on investment analysis before you start measuring your program. And then our next section is our 6-step process to intertwining social determinants of health and social support needs of consumers into your existing program. So, basically, you want to start with what are the assumptions that underline the rationale for us to do this? What is the kind of mission statement for this component of the project? What are the metrics? What population is going to comprise your focus? How are you going to measure? What are you measuring? And once you've done step 1 and step 2, then you can establish baselines with some percentage of the population. You can set targets. You can complete the intervention, and then you can measure and evaluate, taking it back down to item 1, which is your assumptions and what your expected outcomes were. So the best way to look at this is probably an example. So step 1 was a program based on the assumption that one of the reasons that mental health consumers had higher levels of diabetes was, I'm sorry, had trouble with monitoring their diabetes, was that they lived in environments where they had limited access to fresh fruits, vegetables, and proteins. And so in step 2, they assessed all the clients who lived in the zip codes where they knew that there was multiple food deserts. They then surveyed these clients via telephone interviews that were specifically related to food ability, access to cooking equipment, and interest in food preparation. They had 250 people by zip code that they looked at, and their goal was to reach 83 people over a 50-day period. A 90-day period, rather, sorry. So their step 4 was they wanted to get a minimum of 50 people to agree to the intervention and to select 2 of the following choices. 1 was a coordinated trip to farmers markets. 2 was a weekly trip to a large grocery store. 3 was cookbooks with healthy recipes. 4 was online cooking demonstrations. And 5 was a consultation with a dietitian. In other words, they had 250 people in their sample. They wanted to reach 83 people to ask them if they would participate. And then their goal was to get 50 of those 83 people to say yes and to agree to choosing 2 of these 5 potential options to address lack of access to fresh fruits, vegetables, and proteins. The intervention ended up being offered to 63 people. 20 people asked for transportation to a grocery store, 10 people asked for transportation to farmer markets, 60 people asked for the cookbook, 43 people watched at least one online cooking demonstration, 22 people asked for a consultation with a dietitian, right? So the intervention was selected. Everyone had to pick at least two, and 63 people picked at least two, and this is what they asked for. 90 days post the intervention period, 60 people indicated that they had increased their intake of fresh food. 25 people had cooked at least one meal from the cookbook. 20 people completed the dietitian consultation, and 62 people out of 63 were happy with the program. So, you know, is that going to affect blood sugar? Is that going to affect compliance with diabetes regimes? Is that going to cause anybody, you know, to not have their diabetes? And the answer is no, but it moves toward this model where people feel empowered to be their own best healthcare advocates. And in so doing, are more aware of their health, are more aware of how their food impacts their daily need to monitor their blood sugar, and are more actively being, again, advocates for themselves. So it does result potentially in decreased emergency room visits, maybe fewer hospitalizations. Maybe if you go into the hospital, you're staying for shorter periods of time because your disease is better managed, your overall health expenditures. So the assumption underlying this construct of looking at a whole person and helping that person with all of the aspects of their life is that the total cost of care for that person is going to be lowered. Living with a chronic disease, you're always going to have that chronic disease, but you could lower the spikes of utilization and the spikes of need by paying attention to the supports around a person, by paying attention to access to fresh food, access to recreation, how often they go out and have fun with friends, et cetera, et cetera. All of those things together affect a person's well-being. And that's why this is healthcare. So that ends the prepared part of the discussion. At the very end of our day, we will also have a little commercial about our upcoming presentation, but I'd like to open it up right now and ask for questions.
Thanks a lot, Sharon. I'll kick us off. You know, a lot of the social determinants of health and provider organizations are funded with pilot programs and grant funding. And as great as that is, how do executives build longer lasting funding streams that don't rely on pilots and grants?
Yeah, I mean, that's really the most critical question. And I think that that's where the value-based purchasing models are going to come into play. Payers generally already know this stuff, right? Payers already know that social determinants of health are affecting their members and the total spend associated with their members. So if you can get a value-based arrangement where you have baked in the social determinants of health interventions, that's really your best bet for making this sustainable, because you then have an opportunity to get paid basically for doing these services which are outside of the traditional medical environment. If you can't get that kind of funding and you can't get that value-based arrangement, it is very difficult. So you may have to partner with a local government authority that has a homeless program, or you may have to depend more on a transportation program. What's important is to begin, as you're doing that step one, what's important is to begin envisioning for your population, how is our focus on this going to help consumers, and how is helping consumers going to affect my bottom line? And again, in our kind of disconnected world, oftentimes it's not. So then you have to say, okay, this is the right thing to do. How are we going to build this in a way that it is sustainable? And it could literally be as simple as compiling dictionaries, not dictionaries, directories of available services. And so someone indicates there's a problem, and you say, here's the directory. Here are the 5 organizations who can potentially help you with this. So it's not necessarily something you have to do yourself. It can be helpful and therapeutic simply to provide referral, but you definitely have to take a look at that question as you're building these programs, because absolutely it's hard to do these things if you can't sustain them.
Thank you much, Sharon. You talked about things being disconnected. How does provider organization executive break down the program silos that are disconnected often at different organizations and adopt an integrated approach that more fully brings in the social determinants of health?
Yeah, that's another great question. If you look at some of the changes to the service delivery system, right? The creation of the CCBHCs, through SAMHSA, the integration of behavioral health coordination into some of the FQHC models. This is definitely something that we see happening more and more from the federal government's point of view. And so, one of the answers is, how entrepreneurial are you? Can you find a primary care practice, as an example? Can you find a primary care practice where many of your consumers or a bulk of your consumers are being served? And can you approach that primary care practice and talk with them about creating something that's truly integrated? And it doesn't have to be a merger, it doesn't have to be an acquisition, it could simply be a program where you sign on to assist them helping some of the shared patients get some of their social determinants of health met. And perhaps that practitioner group actually pays you to assist with that. So it really, the opportunities are broad without changing the way our healthcare system is financed and paid for. There still is opportunities, including approaching health plans and saying, hey, health plan, we have 100 of your members, and these are 100 people who have really high service needs. So what would you think about entering a partnership with us so that we can start helping you take care of the full spectrum of service needs and not just, fill in the blank, whatever your organization does. So it really is, it's creativity, it's structural. We have to advocate for these kinds of changes in the healthcare financing structure, because it's very difficult to deal with a society where we have these high level of social problems and no coordinated infrastructure to care for them.
Thanks, Sharon. And you talk about speaking with health plans. And a couple of years ago, Monica Oss covered what she called at the time the dark side of social determinants of health. Now, we all know that healthcare, the operations of healthcare today relies on data, lots of data. And this is, for a lot of organizations, going to be another level of data collection. Are we going to run into some problems where consumers are finally becoming uncomfortable with some of this data? And the other side of the dark side was, does this become another way to inform how they set insurance rates? And is this something that we should be aware of going into the future?
Yeah, well, I think that's a great question, Corey. And you and I and others at Open Minds and I have had conversations about this issue of privacy and identifiable information. And I do think that we have to be super careful about the person level information that we collect and how it could potentially be used against somebody even though that's not our intention going into it, how could it be misused and how could it be taken advantage of? And I think that that's our responsibility as stewards of these kinds of services and stewards of the clients who we serve directly. I think you can get a lot of good information and a lot of good intervention ideas through anonymized data. So as an example, if you're just looking at zip code, you can say that in this zip code, X number of people are indicating that this, and this are lacking. And you can use that data. But there are these Z codes, Z meaning they're in the ICD-10 diagnostic chapter under the letter Z, that go into excruciating detail about people's social determinants of health. And I'm very nervous about those Z codes. So the more and more insurance companies are asking for Z codes to be part of the claim that's submitted. On a professional services claim, you have up to 12 placeholders for diagnosis. But the level of specificity of those codes, I'm not sure that I would want my information being transmitted in that way on a claim, because claims data are available to lots of different kinds of people, including people who use it for rate setting. And so, as an example of the specificity, has a history of being the victim of emotional abuse, has a history of being the victim of sexual abuse, has a history of being a victim of physical abuse. But then it also asks for the level of effect on the person, the level of intensity, whether it happened a long time in the past, whether it happened a short time in the past. Like the level of specificity of the codes is really, I personally think, something we have to pay a lot of attention to, because collecting them for our internal medical record is one thing, but collecting them and then putting them on the claim form, which we know is going to be used for all kinds of things, including rate setting, that's a different issue. And so I do think that each organization has to think about how they steward that, and also which social determinants of health Z codes would they put on claims and which they would not, which would just basically be part of a written record but not part of the actual payment request. That issue, it does not get a whole lot of people talking about it right now. It's more kind of, the more Z codes the better. Insurance companies will pay you for collecting Z codes. Certain programs will require collection of Z codes. So I do think that every organization has to take a look at its own kind of ethical stance about that. But I agree with you. I would be nervous about that.
Thanks, Sharon. Great answer as always. I have another question for you. A lot of the conversation today was about, how do you build a business case for addressing social determinants of health? And for a traditional healthcare organization, whether that's behavioral health or physical health or some form of integrated care, as the saying goes, when you have nothing but a hammer, everything kind of looks like a nail. If you've engineered your organization one way, is it just a matter of applying that organization to this completely new outlook? Or do you have to retool completely? Do you need to bring in new staff? Do you need to bring in new tech? How easy
Right.
is it to transition from, you're just not tacking on. It's not as easy as tacking on, we're going to now attack this from another angle,
Sure.
How do you build the business case and engineer your organization to succeed?
Yeah, I mean, that really is the most important question that anyone could ask about this. And I don't think there's one easy answer. I do think when you're rearranging your deck chairs on the Titanic, if I could, postulate that our healthcare system is probably not sustainable forever in the way that we currently pay for healthcare. Again, which is one of the reasons why we're moving towards this more, value-based model. But on some level, retooling without significant change doesn't matter, because now the deck of the ship looks beautiful, but you're still going to hit an iceberg and die, right? So, part of it is that design component. That first step is, what will happen to us if we don't do this? What will happen to us if the world shifts and changes, value-based becomes much more prevalent, and all of a sudden, what we do is there's no longer a demand for it because other people are doing it. So one of the things that Monica said in a presentation that she did earlier was that a lot of the health plans are building their own intensive case management teams. And that doesn't mean intensive case management as it's defined in the mental health world. It means that they're employing people who will be case managers for their members who have a lot of related issues. And so, what happens when Medicaid expansion reduces the number of people who are uninsured, and the Medicaid MCOs, which are the big national MCOs, have decided to start doing some of the functions that your organization is doing, themselves. So it's a conversation you need to have, and I don't mean to catastrophize. I'm not saying that everything we do is going to go away, but it is that question of what will happen in 3 years, what will happen in 5 years, and what would we do if the demand for our services ended? How do we make our services something that's so attractive that the demand will not? How do we think about going to a health plan and doing a partnership with them? So like, what is your expertise that you feel so proud of, and how can you think about marketing that to outside of your traditional kind of, I do my service, I submit my claim form, and I get paid? It really requires a brainstorming of the entire leadership team, and it requires a level of kind of jumping off the cliff that not everyone is going to be comfortable with, not everyone's going to be able to do. But for those of us that can do it, I think it's going to be really interesting. The second answer to that question is, if we do ever move toward some kind of a Medicare for all or nationalized health insurance infrastructure, then all of a sudden the work that everyone on the Health and Human Services side does is going to be really, really important. And if we could ever tip our health financing over so that we are not spending only 56 cents of every dollar that we spend on healthcare on social services, if we could get it to $1 on social services and $1 on health, or even the way it is in the OECD where they're spending more on social services than on health, then all of a sudden our agencies and the traditional serving agencies become much more viable and have a much more important role to play.
Sharon, thank you. This has been great. We've come to the end of our time.
You're welcome. I will put up Joe's face.
Absolutely. I want to remind everybody that we are here every Thursday at 1 p.m. Eastern. Next week, we'll be back with Building Your Diversification Strategy, how to assess and develop new service lines, possibly social determinant focused service lines. That will feature Joe Travers, Senior Associate for Open Minds. We would like you all to join us. I want to thank you again for coming today. If you have any questions whatsoever, you can contact me at C as in cat, THORNTON at openminds.com with any of your questions. You also have access to a 1-hour quick consult with some of our senior associates where you can continue this conversation a little more intimately. Tomorrow, the slide deck and video for this will be available on openminds.com. Sharon, thank you again.
Thank you. Bye.